Hello there. This is Andrew Colsky again with Therapy Behind the Scenes. And we have a guest today, Germain, who is going to talk with us about sleep and sleep issues. And I have to say, I've really been looking forward to this particular episode because it's an area that I'm really interested in. And Anne has been, helping me in the background by explaining a lot of this stuff to me. So we decided let's do a podcast and talk to everybody else about it. So, Anne, can you introduce yourself to the audience?
Absolutely. Thanks for having me. I too am very excited to participate in your podcast. So I'm Dr. Anne Germain. I'm a clinical psychologist by training. I've been in behavioral sleep medicine since my very early days in academia. And I'm originally from Montreal. So if people are wondering where the accent is from, it's actually a French Canadian accent. But currently live in Pittsburgh. I've been in Pittsburgh since 2001. I came here to do my postdoctoral training. Then I joined the faculty of the University of Pittsburgh in the Department of Psychiatry. Had a large program of research there really focused on uh, developing, validating, testing treatments that work for sleep disorders, primarily insomnia and nightmares in the context of um, post-traumatic stress disorder, pretty much working almost exclusively with the US military. And another branch of my research program, I was focusing more on the neuroscience of sleep. And had stayed at the university for 20 some years, the University of Pittsburgh, until I really wanted to find a pathway to take the findings that we had in the research lab outside into the real world so that we can benefit really all the patients, but also the clinicians who take care of patients with insomnia, nightmares, and other kinds of sleep disorders.
Mm-hmm. Wow, that's an impressive resume. But I got to ask you one question that I'm curious about related to that. And since this is therapy behind the scenes, it's a behind the scenes type of question. And that
Yep.
question is, so it sounds like from the very beginning of your work, you started with sleep. What was the fascination with sleep? How did you get into that particular area?
Um, I was very lucky. I was in the right time at the right place in the summer when I was an undergrad working in a research lab where one of the graduate students knew of someone, the director of a lab focused on dream research. And they were looking for a research assistant. We got connected, and the person at the sleep lab there, at the dream lab, his name is Dr. Tori Nilsson. The first thing he told me is like, well, if you're interested in this position, what I want you to do is sleep in the lab as a research participant for 2 consecutive nights. Then I'll ask you to work the night shifts and be on the other side in the room, and you'll see what it looks like to do dream research, and then you and I can meet and you can decide if you want to do this kind of work. So the first 2 nights were awesome. I slept in the lab. It was perfect. And then the next 2 nights, the first night I really got addicted. It was fascinating to me to see people with, the electrodes and all the montage where we can see their brain activity, muscle activity, and to see people fall asleep and to know when they were dreaming, even though the person is sleeping. And actually, the research at that time, the research project was required that we woke people up at the end of each dream period to
Mhm.
collect their dream reports. And it was absolutely fascinating to me. And so when we did meet after the fourth day, on the last morning, I said, I'm hooked. This is really what I want to do. And I've never left. So I kept in sleep research. And I ended up one of the research projects we were working on was really looking at people with frequent nightmares. And because of that work, I had the really the privilege of working with people who had gone through extreme life stressors and traumas, and listening to their stories where it was and really hearing the strength and the resilience. And what pretty much everyone said in one way or another was, if only I can get one good night of sleep, I can manage the rest. And I thought, I can do that. I can work towards giving one and many more nights of good sleep, um, and give people a break. And just ultimately, the world is a better place when people sleep better.
Right. Absolutely. because I do the mental health counseling part of this field, I
Mhm.
work with patients that have anxiety or PTSD or one of any sort of issues. And every once in a while, you get that patient who reports that they have trouble sleeping, and they'll go through everything that they've tried and done. And I never, in my school, they didn't really teach us anything about sleep at all. And now I'm seeing the value of the work and the things that can be done and all the things that we're going to talk about today. So it's really exciting to me to be able to share this information.
That's great. And you're absolutely right. I mean, most any kind of undergraduate or graduate training has very little education in sleep, which is especially in mental health. I mean, it is a third to a quarter of our lives that we're sleeping. Sleep is, really a core biological state. We need to have restorative sleep to function at our best and feel at our best during the day. So the fact that there's very little training, or that people have to be very proactive to find the training in sleep medicine and behavioral sleep medicine, especially, contributes to some of the challenges that we have in the field and finding the right expertise, and most importantly for patients to getting to the treatments that work relatively quickly.
Mm-hmm. Yeah, and I'm in tune with what you're saying because I'll share with you and share with the audience that so I was diagnosed with sleep apnea many many years ago. So I went through all the sleep studies and having all the
Mhm.
wires connected to me and sleeping in a strange bed and all the things that you do, and it did make a big difference once I got the proper treatment. And so I've had the opportunity to be on the other side of the fence, I guess. Um,
Yes, and unfortunately for sleep apnea, there are many clinics and sleep labs that specialize in sleep apnea, and I think the resources and getting people to getting the right tests, the right diagnosis, the right treatment options is a bit, I think, a much easier when we're looking at sleep apnea than when we're looking at the other most common sleep disorder, which is insomnia, or the other behavioral sleep disorders, the one that are best treated without medications. That's hard to get to the resources and the expertise that is needed then.
yeah, and that goes right back to what we were saying before, is that they don't train that in school, so people just don't have the benefit of any knowledge in the area. So,
Exactly.
you know, so then tell us, what would you, how do you define optimal sleep?
Optimal sleep, there's four characteristics really of to optimal sleep. Um, Optimal sleep is predictable, meaning that you know when sleep is going to happen, you know when sleep is going to end. Optimal sleep is also consolidated, meaning you fall asleep and you stay asleep. I mean, we all wake up a few minutes here and there throughout the night. That's absolutely normal. But overall, we should have the feeling when we wake up that we went to bed, we're out of it for a period of time, and then waking up. So that's what I mean by consolidated. The third characteristic is restorative sleep. It's one thing to know when sleep's going to happen and to fall asleep and stay asleep, but it has to do its job in terms of like restoration of like body and brain functions that happen during sleep. So the feeling of being rested, of being ready for the day, that's really the third characteristics of optimal sleep. And the last one is sufficient, having enough of an opportunity to sleep on a nightly basis. So those four characteristics are predictable, consolidated, restorative, and sufficient. And if you notice, when I mentioned sufficient, I didn't mention a certain number of hours that people need. There's this myth that we need 8 hours of sleep. But really, most adults will function well between 6.5 and 7.5 hours of sleep on a nightly basis.
Hmm.
Sometimes a little less, sometimes a little more. And what is sufficient, how much sleep is needed, is really determined at an individual level basis, if you want. We all have our individual sleep needs. And I always tell people, well, if you could go to bed whenever you wanted and you could get up without the alarm, how long would that take for you to, by the time you wake up, feeling rested? Assuming that they don't have another underlying untreated sleep disorders during that period. And that's usually sufficient. What sufficient sleep means, meaning having enough of an opportunity for sleep to do the jobs that it does, but also to wake up rested and ready for the day.
Mhm. Well, as you were describing that, I was thinking to myself that originally I'm from Miami, Florida, and down in Miami we have hurricanes. And when a hurricane comes through, it knocks out your power, and the power's out for several weeks. And I'm just thinking back to, when you don't have the hum of the air conditioning, when you don't have street lights, when you don't have any of the distractions that we normally have, your sleep desire is different. I actually get better sleep when there's no power or anything. And I wonder if you could just kind of comment on that.
Well, that's not surprising, because even though a hurricane, I'm sure, is a very stressful situation. As I said, I'm from Montreal. We don't have hurricanes there, but despite the stress of the situation, to your point, there's no electricity, there's no distraction. All the background noise that we don't necessarily pay attention to, but is there constantly. All sorts of stimulations that are dependent, contingent, even the fridge on having power. When none of these kind of stimuli are available for your brain to keep busy and process, even if it's just monitoring in the background, when none of that is there, basically your entire brain is available for whatever is happening. And if there's much less happening, there's a fair chance that you're going to sleep easy, like fall asleep easily, more easily maybe, and sleep a little bit longer, because there aren't all of these distractions to wake you up or to keep your mind a little bit busier than it should while you're sleeping.
Mm-hmm. Yeah. Wow. So then that leads me into the question of sort of the opposite, which is, so what is insomnia then?
Oh, insomnia. There's very clear definition. There are many things that masquerade as insomnia, if you want. So insomnia is really defined both from its nighttime component and the daytime component. So from the nighttime component, we think of insomnia, we define insomnia really as a difficulty falling asleep or staying asleep at least 3 nights a week for at least 3 months. It doesn't mean that you can't intervene if it's less than 3 months. But that's really this idea that when you want to go to sleep or when you want to be asleep, there's much more wakefulness happening at the wrong time, if you want. That's the nighttime component for insomnia. And it's important to remember that even though insomnia, yes, is a sleep disorders, but typically people start considering that this is a problem when it also starts to influence their functioning during the day. So, and it comes like the impacts of insomnia during the day, they come in different shapes. So it can be that your mood is affected, your motivation is lower, you're more irritable. It can be that your mind is foggier, that it's harder to concentrate, having memory lapses. It can be physical symptoms, or sometimes having problems with just like being able to perform at work or at school. So, and that's typically when people start seeking help or seeking solutions for insomnia. It's not just with the sleep, the nighttime component, although there's plenty of reason to address the nighttime component as soon as possible. But typically, and I'm sure it's the same in your practice too, people will say that, what motivated them to seek a solution for insomnia is that they missed an important event because they were too tired, or they're getting into more arguments with friends and families because they're a little bit short-tempered because they don't sleep as well. So it's when those daytime consequences become more noticeable and get in the way of people's life that's when people will start seeking help for insomnia.
Right. So if I was someone who didn't know a whole lot about sleep, I think I'd be wondering, so then if I'm not sleeping well, or I'm having these troubles during the day because I'm too sleepy, I'm not getting restful sleep, how do I know if I have insomnia or sleep apnea or something else? How do I know?
Um, if well, there's some different questions that you can, or different aspects that you can look at. If you go to your primary care doctor, for example, and you say, "I'm not sleeping, I'm tired all the time," they'll ask you most likely if you snore, or if your bed partners complain of very loud snoring, if you wake up gasping, choking for air. Those are typically more common symptoms of sleep apnea, right? It's the upper airway. You can't breathe while you're sleeping. So, of course, you're going to wake up because that's the only way your body and your brain have to make sure that you keep breathing while you're sleeping. So there's a key distinction in symptoms for sleep apnea or for the other disorders. Restless leg syndrome is another kind of conditions where people say, well, I can't fall asleep. I feel I have these creepy crawly feelings in my legs. It prevents me to fall asleep. And they'll call it insomnia, but it's really another kind of restless legs, for example, it's another sleep disorders. So if you go to your primary care doctor or a sleep doctor, they'll ask a series of questions to try to categorize the symptoms and say, is it insomnia only, or is it another sleep disorders? Sleep apnea could be a restless leg I mentioned, or is it likely that it's a combination? Sometimes it's a combination of two sleep disorders. It's not uncommon that insomnia happens with sleep apnea. So someone may have breathing issues while they're sleeping and have insomnia on top of it. But actually, on that point, oftentimes insomnia comes with another kind of medical or mental health condition. So insomnia and depression, insomnia anxiety, and insomnia and diabetes, and insomnia sleep apnea. So if you go to your primary care doctor or sleep doctors, they'll ask several questions to understand, is it just insomnia? Or what are the comorbid conditions that contribute to the insomnia? And based on this, formulate like what's the testing plan that makes more sense. If really we think that it's primarily insomnia that is at play, you don't need to sleep in the sleep lab like you had the experience for sleep apnea. Just based on what people report, they can go straight into the treatment or the intervention. If it's sleep apnea that is suspected, then you're likely to either go to a sleep lab to be tested, but now there are many different kinds of technologies that bring the sleep lab to the patient's home. So devices that people can take home that will evaluate breathing and movement while people are sleeping to really have a good diagnosis, and then based on the diagnosis, determine what's the course of action. If it's both insomnia and sleep apnea, it's called comorbid insomnia and sleep apnea, or COMISA. I'm sure you've heard the term. Then you're likely to have the treatments for both, the treatment for sleep apnea and the treatment for insomnia.
Right. Well, so I want to get into a discussion about the treatments in a second, but before we do that, I'm curious for your feedback on, so client is having trouble sleeping. They don't know why. It's disrupting their daily routine. They get so frustrated with it that they will try some home remedies, maybe alcohol, maybe marijuana, maybe some over-the-counter pills. Are those helpful? Are they destructive? Can you tell us what should people be doing?
So for the over-the-counter supplements or anything that says drowsy on it or ZZZ on it that you can buy over the counter, they can help in the sense of like making people feel drowsy. The issue oftentimes with these types of over-the-counter products, if you want, is that they don't induce natural sleep, right? It might help to fall asleep, but then it has consequences on the depth and the consolidation of sleep as people are sleeping. There's also the kind of secondary danger, if you want, that people develop the dependence or this idea that they need to take something to be able to fall, as one of those supplements to be able to fall asleep, which is typically not the case. For alcohol, I mean, this has been very well studied. At low dose, yes, everybody feels like a little bit slower, a little bit drowsier with alcohol, and it can help, not in the good way, but it can accelerate people's falling asleep. But with alcohol, for example, it helps to fall asleep, but once it's metabolized by your body, what happens is that it's this surge of activation that happens. So it's almost like putting a lid on the activation that prevents the person from falling asleep. But once the lid is lifted while you're sleeping, you have this surge of activation that occurs. So that's why if you've had a night where you had maybe one or too many glasses, you'll fall asleep quickly, but the rest of the night is going to be very fragmented. That's just on one night. So repeatedly, that becomes quite detrimental in terms of health. And you mentioned cannabis. We are so behind in sleep medicine in understanding the effect and the short term and long term impact on cannabis, on sleep generally. I don't think we have any kind of good data when it comes to specifically in the context of insomnia. There are
Mhm.
some studies that look at people that have been using cannabis for an extended period of time and look at their sleep. And typically, I would say kind of the general signal that comes out of those, the few studies that we have, is that it seems to be, sleep still seems to be disrupted with cannabis. But again, in the context of insomnia, we have so little information that there's really no kind of clinical guidance that we can afford, that we can offer to patients on that front yet.
Wow, interesting. Yeah, yeah. I would have thought that would have been more heavily studied, but I guess it hasn't been yet.
No, unfortunately, it's oftentimes like it's not uncommon that I'll speak with someone or had patients in the past that would ask me and tell me what their experience was with cannabis or different products. And I was like, well, I can only take your word for it. Like I don't have a professional opinion. There's nothing to base that opinion on, or not enough to be able to have a solid opinion.
Mhm. So with all that, then, is there an evidence-based treatment available for insomnia?
There is are the best and the safest and the most durable treatment for insomnia is called cognitive behavioral therapy for insomnia, or CBTI for short. And that's like in the name, it's says it's really a group of techniques that don't involve medication. That's why we call it behavioral. That basically retrain the person's brain and body to develop optimal sleep so that it's predictable, restorative, consolidated, and sufficient. And so CBTI is this group of techniques that people implement in their daily routine, both during the day and at night, that helps really boost the signal or the mechanisms that control sleep. So there are two brain mechanisms that are hardwired that contribute to optimal sleep, that control sleep. One is the sleep drive, which is basically the longer you're awake, the sleepier you get, right? You're more likely you are to fall asleep. And the other one is the biological clock. We're wired to sleep at night. Most of us are wired to sleep at night and to be sharp and alert during the day. And our biological, we have many, but the brain's biological clock is kind of keeping time of day and helping us stay awake during the day and stay asleep at night. So CBTI uses behavioral techniques or strategies, if you want, that boost and realigns these two systems so that we can really achieve optimal sleep.
Right. Well, it makes a lot of sense, and I certainly can understand the tie-in with the daylight and nighttime and all that. But I know the question is going to come up. Well, what about people who work shift work and are working at the nighttime? Then what do they do?
Well, then they have an extra challenge. So then their challenge becomes, how do we adapt these techniques so that we can have the best possible sleep during the day and be optimally alert and sharp at night when we're supposed to be sleeping? So then it becomes like more managing these environmental requirements or job requirements. So it's really, how do you optimize your chances of sleep when you're sleeping at the wrong biological time, if you want, or at the suboptimal biological time? How do you optimize safety really, and reduce fatigue when you're awake, but your body is really trying to work to keep you asleep. But the bottom line is that the principles of how to achieve this without it, with it, whether it's in the context of shift work or when there is no shift work, the behavior and the principles are very much the same.
Mhm.
Um, and so if you take a shift worker, for example, that has insomnia as well, you would modify the insomnia treatment to account for the fact that we're going to ask people to sleep at a time where it's more difficult to sleep. So how do we allow them to sleep maybe more than once in the day so that they can have in total enough sleep before they go back to their shift work schedule?
Mhm. Wow. It's got to be hard to adjust to that, I would think. If you've been working a 9 to 5 and then you switch, everything gets kind of thrown off.
It is difficult, and it's, think of it as, like if we're thinking of insomnia and CBTI for the treatment of insomnia, it's like any other set of healthy behavior that you want to achieve, right? Whether it's diet or exercise or sleep, really the three pillars of health. But it requires, that to be mindful and kind of disciplined to maintain the good habits. And the same thing is true for sleep. It's always more difficult at the beginning than after, like when you get into the routine, for example, of going to the gym. It becomes much easier than the first few weeks that you start going to the gym. The same is true with sleep. So, or insomnia, the first few weeks of CBTI are not easy to go through. People are tired, but with the discipline, very quickly they see the benefits of these new behaviors. With shift work, you have this, it's the equivalent of trying to get on a healthy diet, but the only option for anything sweet is chocolate cake, a big piece of chocolate cake. So, if this is true, if this is the truth, that there's shift work, that there's this additional challenge, then it means, like, how do you build in the discipline to kind of mitigate the effect, given that it's not something that people can easily change. If you're a firefighter, for example, you can't just fight fires between 9 and 5, right?
Right. That
So
would be
so
nice.
it would be nice if it was scheduled like this. So there are many different type of jobs and careers that people have that inherently require shift work. It creates a tremendous challenge for sleep, of course. Well, many different challenge, but certainly one for sleep quality. And then it really becomes a question of how do we optimize sleep when people can sleep, and equally important is how do we optimize their alertness when they're working. Oftentimes, I mean, if you work night shifts, oftentimes those jobs are high demand, or they might be like, relatively steady, but then something happens and you have to be real quick and react. So that's an extra challenge, but
Wow.
it's also manageable. I don't want
Right.
people to think that, it's really hard, it's not doable. It's like, no, it's doable. And there are protocols for this. We have the kind of the guidelines of how do we implement it. And then it really becomes like a question of tailoring it to each person so that it makes sense in their lives too.
Mhm. Well, it's relieving to hear that there is a whole uh, process out there for someone with insomnia, and that
Mhm.
it's helpful, and we've got all this evidence and studies. But what about the person with apnea, sleep apnea? What did they do?
Oh, they have many different options. So when it comes to the treatment, when it comes to treating sleep apnea per se, um, if you look at CPAP machines, are certainly one of the common treatment for people who have milder sleep apnea or milder form of sleep apnea. Dental appliances can be very helpful. There are actually medications that are coming to the market to help kind of tone the muscles of the upper airway and keep the airway open while people are sleeping. So there are a number of kind of treatment options that are many more that are available for sleep apnea than we have for insomnia. Uh, and there are also the other type of options that are available is that when people are treated for sleep apnea, for me, the treatment of sleep apnea is almost like the treatment of insomnia with medications, right? We have good medications too for insomnia. They're not the first line treatment. CBTI really is the first line treatment. But like with sleep apnea treatment options or medication options for insomnia, it's almost it's very much a combination of arts and science to find what's the right intervention or what's the right treatment format for a given person. There are people that use a CPAP and the very first night it changes their life. They feel better, they love it, they'll adhere, they'll stick with it, and there are people that will try many different options, and it's not for lack of trying, but they'll have like not the same level of success. So even for there are some other types of treatment options that are like basically implantables that can also help with sleep apnea. But the best strategy is really depending on the severity, depending on comfort levels to other conditions that the person might have. There are usually like if you want a list of what's the first line in treatment, really, I think typically it would be CPAP. But then to consider what are the alternate if people are either not ready to use the CPAP or maybe it's a light form of sleep apnea and a dental appliance would be a good option for them.
Wow. It's nice to hear that there's a lot of choices there because, I know a lot of people with sleep apnea. But then here's where I think a lot of people would get confused. So hopefully you can clear this up. We've got primary care physicians. We've got sleep doctors like MD. We've got sleep professionals, PhD doctors like yourself. We have sleep therapists, something that I do. How does a person know where to go to get started?
That's an excellent question. What I was going to say, my first answer was going to be, well, fortunately, the healthcare providers are very aware of the importance of sleep and sleep health, and the sleep professionals, the resources that are available when it comes to sleep clinics, to psychologists, to therapists that are available to their patients. Sometimes primary care doctors will manage insomnia with their patients. They may also manage sleep apnea with their patients. So there's some practices that will take care of the sleep problem in-house. There are some that prefer to refer to other to sleep centers, for example, to sleep clinics. For But your question is where would one start? I would say the good place to start is to talk to your primary care doctor and to say like, look, I'm having these sleep issues. And the first thing I would ask is, what are the resources in that region? Who do they work with sleep clinics? And so I think it's insomnia. Who do you refer to for CBTI? Um, and and go from there and see like what the consideration are for the options. Again, like for medications might be an option for some patients. Oftentimes, though, the medications that we have for insomnia, they can be effective, but they're typically recommended to be prescribed for just a month, like 30 days at a time, to kind of get over a tough period, but not necessarily to become a chronic use, because oftentimes over months or years they become much less effective. So that might be part of the treatment planning to say, well, maybe having, especially if there's a long wait list to get to the one specialist for sleep, to say, well, to get a prescription for sleep medications. But I would say primary care doctor is probably a good source to see what are the resources, the sleep resources available in the area. And then, of course, the internet is an endless source of information. And actually, in sleep medicine, the Society for Behavioral Sleep Medicine, the American Academy of Sleep Medicine, as well have patient resources, and there are directories that are available. So if you say, I'm looking for a therapist to help me with my insomnia, there are a repository, or you can search through different websites, finding like therapists or psychologists they're the same. They do the exact same treatment, really.
Mhm.
So, um, and to find like who in your area is available. Do they take your insurance? Do they take new patients? Who did they refer to? So there are resources to find access to the right expertise to get the treatments.
Wow. So when we talk treatment, I want to make it clear for someone watching this, not everybody has to go into a facility and get hooked up with all the wires and sleep in a strange bed. Who are the ones that need that versus people who can just do, you know, maybe even telehealth?
So unless you have clear symptoms, um, two reasons. If you have clear symptoms of sleep apnea, so somebody's snoring very loudly, waking up gasping, choking, witness like they're being told by their bed partner that they stop breathing for many seconds at a time at night. If they're sleepy during the day, or they had almost their near miss car accident because of sleepiness, or they're having problems at work, these are really like core symptoms that may not be just of sleep apnea, but that one would want to get tested to at least rule that out. And that, as I said, that can be done in the lab with all the electrodes and everything, or it can be done at home too with a few sensors that the person puts on themselves, and the information is sent to back to the doctor for review. So it's either in the lab or at home sleep apnea testing that is feasible. Um, and unless someone has symptoms of um, any of the hypersomnia, and that's basically the group of sleep disorders where even without sleep apnea, people are extremely sleepy during the day. So the people who could be people who have symptoms of narcolepsy, that which basically their sleep and wakefulness is very fragmented. People can fall asleep like this anywhere, anytime, without being sleep deprived, of course, and or people that will sleep like 10, 12 hours and still not feel rested. In those cases, typically you'll want to have someone, you might want to have a study, if not to rule out sleep apnea, to see like the depth of the issue like during the daytime. But for insomnia, no need to go to the lab, no need to have sensors, nothing. We don't have an actual objective measure of insomnia. Insomnia is totally based on people's experience of their sleep. Feel
Mhm.
like it's like taking a long time to fall asleep. Feels like you're waking up more than you should, or you're awake for more than 30 minutes at night. It's completely based on the person's experience, not on any kind of sleep lab test that we could do.
Right, right. Wow. So, so basically, the good news for the audience is you don't necessarily end up in a sleep lab if you have sleep problems. It's only a specific,
Like, yeah,
number of people.
for a specific group of people. The other case I would say that you might want to have a sleep study done is, for example, you come with insomnia, there's no other symptoms or no other hints that there could be another sleep problem at play here. You go through a course of CBTI, and after 3-4 weeks, both you and your therapist are thinking like, for the work that you're putting in, we would have expected your sleep to get a bit better at this point, and it's not moving as fast as one would expect. Then that's the other time where I would consider recommending a sleep study, just to make sure, like, is there something going on that we don't know of, that we haven't detected, that is kind of holding the person's back in treatment? And if we can address that hidden factor, we can really get the optimal effect when we're when people are completing CBTI.
Mhm, mhm. So, so then, you've mentioned a lot of different things that can be done. And, one of the questions that I'm sure people are wondering is, so we have these things, we have the Fitbits and the Apple Watches and all these different types of technologies. And I even have seen on the internet for like sleep apnea, you mentioned there were a ton of different devices.
Mhm.
What's going on currently in the sleep medicine industry, technology wise?
Oh, that that would be a topic for an entire podcast. But Because there's a lot, and I think there are different drivers for this. I mean, people are interested in their sleep. People want to sleep well, want to have healthy sleep, and actually, people spend a lot of money on sleep products. So it is a lucrative business for consumer devices or consumer products in sleep, and that includes the mattresses, the pillows, and in addition to those wearables and different things that you can buy for your bedroom with the idea of optimizing sleep. In the sleep field, I would say the first thing I would say is that not all wearables are equal when it comes to measuring and detecting sleep. Some wearables are better than other. There's a team, a partner group that we've worked with for many years now at Naval Health Research Center in San Diego that has done validation and comparison studies with different wearables relative to research grade wearable that we call actigraphy, and the sleep studies that you were mentioning earlier. And some wearables are better than other at detecting sleep and wakefulness at night, and some are not that great. So I would actually look at what kind of recommendations these wearables get from sleep experts or in validation studies. They come with a lot of additional information, like sleep staging or things like that are provided. Most of us in sleep medicine give very little attention to that.
Mhm.
Because, like, for example, deep sleep and REM sleep, they are generated by your brain by like nuclei in the middle of your brain and deep in the brain. It's really hard to believe that we can measure that accurately on someone's wrist or someone's finger. And actually, the validation studies show that this data is not physiologically true, right? It's interesting, it's entertaining, people want to know, and that's great. But in terms of the physiology and how do we use this information to inform behavioral treatment, we don't use that information. I
Mhm.
think there's the last thing I want to say is that it can be like, typically, when the two things I want to say, one is when people are sleep minded and want to have healthy sleep, like anything else, tracking your sleep, tracking your diet, tracking your exercise, this is really well established that it helps people keeping healthy behaviors. So they may be helpful, but once you start having sleep problems, what's the device going to tell you that you don't already know? And none of these devices, to my knowledge, currently provide evidence-based recommendations to say, well, your device said you had 40 minutes of awakening, and based on your profile, here's how you reduce it to 10 minutes. None of these devices do that. So I've seen many people, patients, saying, "Oh, well, that's kind of, my sleep was bad. I got this device, and it's telling me that my sleep is bad, is bad, and it's just a double frustrating." It's like, but it doesn't tell me what to do. And it's right. Monitoring is a good thing if you don't have a sleep problem. Once you have a sleep problem, it might actually become more frustrating. And I've seen people, and there's such a thing as a orthosomnia, people developing almost like sleep performance anxiety, right? Because they
Hmm.
look at the number on the device and they're saying, well, the device saying I don't sleep well, but I thought I slept fine. So then they start adopting all these behaviors to try to beat the numbers or
Right.
influence the numbers. But effectively, what they're doing is they're taking on like a whole bunch of sleep behaviors that are ineffective and is actually fragmenting their sleep. It's actually detrimental for their sleep. So, in the context of insomnia or just more generally behavioral sleep medicine, the consumer devices are not particularly helpful. They may be interesting. They can provide kind of an additional source of information for some patients, but generally speaking, they're neither sufficient nor necessary to show improvements in sleep.
Mhm. So basically, they may measure something, but without putting it into context, it doesn't provide
Yeah.
any, cures.
It measures when you're active and inactive over the 24-hour period for multiple 24-hour periods, which is one type of information for sleep. but it doesn't tell us anything about the quality of sleep, about the depth of sleep. And I'm not talking about deep sleep here. I mean, really the restorative aspect and consolidated aspect of sleep.
Mm-hmm.
So that's the jury's still out there to see how we can use them in a way that is most clinically helpful for people who have insomnia.
Got it. Got it. So that's helpful. So then, I mean, it's just amazing the wealth of information that you have and that you're sharing, and I'm so appreciative of it. So tell me then, what do you see in the future? Where is sleep medicine going? What do we need to do?
We need to bring sleep medicine in medicine. To your early point about, there's from the very beginning, there's little education about sleep. Yet sleep is at core, a pillar of health. So thinking of it as separately, I don't think is of the best service for patients. And bringing behavioral sleep medicine into sleep medicine. So, the treatment of insomnia is typically done not at the same place where you get the evaluation for sleep or for sleep apnea or in the sleep clinic. It's not, I don't want to overgeneralize, but it's not uncommon for people to have to go to one place for insomnia, to another one for sleep apnea, uh, and go back to their primary care for another type of issues. So consolidating sleep medicine back into health, wellness, and medicine more generally. I think there are, and to your point about like the business of sleep, if you want, or consumer products in sleep, there's also a lot of advances being made in leveraging technology to be able to scale the capacity of the doctors, whether it's primary care or whether it's the sleep doctors, so that they can see, manage, diagnose, treat more patients. And it comes in the context of adapting, if you want, the treatment delivery and the dose of treatment, the type of treatment that best match the patient needs. So telehealth, with COVID, as existed before COVID, but has boomed with COVID by necessity. But it's given a lot of doctors and even patients to have the experience with telehealth to say, like, yeah, that can work too. That's good too. And then there are other solutions where people can have with the clinical supervision, but not necessarily having a dedicated time for face-to-face connection. And there are other types of digital tools that patients can use to self-manage for insomnia. So I think the future, to answer your question, is going to be in finding mechanisms and solutions that make sleep medicine doable for all healthcare providers, or at least the first level of sleep medicine by all healthcare providers, accessible to all patients at wherever they seek care, and still have this better defined stepped care approach patients, if you want, for insomnia, for patients who can self-manage. There are some good books, some good apps that they can use. For those who need a little bit of clinical supervision and touch point with an expert, they can have this, and having the telehealth or the standard face-to-face therapy available to them too. So I think in terms of the future is going to be, how can we leverage technology to better match clinicians and patients' needs, so that they can deliver the treatment for the healthcare providers and for the patients to receive the treatment in the way that makes them best sense for them.
Mm-hmm. Wow. So there's work to be done, but at least it sounds
Plenty.
like we have, technologies and things to let us start to do that.
Yes, and to your point, there's a lot of work to be done, many, many patients to be treated. So we need all hands on deck. So the more therapists and clinicians and healthcare providers, nurses, social workers, physicians that we can recruit, there's plenty of work to do, plenty of good to be done.
Mm-hmm. Great. So tell us then, as we start to wind up here, what is your relationship to Noctum Health, and what does Noctum Health do?
I'm the founder and CEO of Noctum Health, And what we do is what I was just mentioning is developing one of these pathways so that we can upskill clinicians who are not sleep expert and really scale clinicians' capability to serve more patients with insomnia and the other behavioral sleep issues at the point of care. Um, there are about 550 experts in CBTI around the world, and we need many more than this. I've been in behavioral sleep medicine for 25 years, and every year we say we need to train more people if we want to be able to treat more patients. In 25 years, nothing has changed. And that's one reason why I left the University of Pittsburgh to found Noctem, is to say, well, if we really want to solve this problem, we need to take a different approach.
Mhm.
And the approach we're taking at Noctem is developing basically a software platform that guides clinicians on how to deliver behavioral sleep medicine, including CBTI, in a way that is consistent with our best practices by guiding them in each step of the treatment. And that's where technology can be very helpful. And for patients to basically have a way to be able to have access to the treatment, their clinical experts, and when I say experts, their clinician, really, to be able to go through the course of treatments that are most efficient. So we have basically it's called a clinical decision support platform. So it's a software that is designed for healthcare providers, any and all healthcare providers, so that they can treat their patients. And the patient component of the platform is really designed to make it easy to share daily information, to share symptoms, to monitor progress, and to provide very specific instruction, very tailored instruction to each patient on how to implement those sleep behaviors that will ultimately lead to optimal sleep.
Wow. Wow. Sounds like you got a lot packed in there, but very effective.
So far, yes, we show the same kind of effectiveness as we show with the more traditional, the gold standard of face-to-face CBTI. Our patients start the treatment, finish the treatment. 85% of the patients finish the treatment. Adherence is excellent, and so it is a viable solution. But as I said, it's one solution. There are many people with insomnia, and they don't all need the same treatment delivered the same way at the same dose.
Right.
So this is what we're working on, is that there's a gap, there's a void, if you want, where you have the patients who can't quite do the treatments themselves, but don't necessarily need to have the one-to-one level of attention over 6, 7, 8 weeks. So for some patients, this is the right solutions. For patients, the right solution is the standard treatment. And there's people who have the discipline to go through some of these self-guided programs and do well too. I'm sure there will be new solutions, and I hope there will be new solutions as well, because as I said, there's a lot, 2.5 billion people suffer from insomnia
Wow.
globally.
Wow.
So I don't think I think we're far from reaching the point where we have too many solutions.
Right. Right. Yeah. It sounds like we don't, like you said, we don't have enough providers to provide the solutions that we do have.
Yes, and the providers that could provide oftentimes think that it's too demanding. It doesn't fit in their workflow. They don't have the level of expertise that they would like to have to feel confident. And the truth is that it's the good thing with behavioral sleep medicine is that it's very prescriptive. We know what the biology of sleep is. We have very specific techniques on how to improve sleep, very clear cues of whether it's moving in the right direction or not the right direction. And because it's so prescriptive, and that's one of the reasons why we use the technology to increase and scale behavioral sleep medicine at Noctem, is that because it is so prescriptive, the magic that happens is the clinician judgment. But all clinicians already have the expertise to decide what is best for their patients. So by providing the technology, we really hope that we can provide the tools to any and all healthcare providers so that they know they can be confident that they're adhering to the best practices, but the technology doesn't guide what patients do. The clinicians drive patient engagement and outcome as well. So we want to give the tools to the patients and to the clinicians and their patients so that they don't have to wait on the wait list for 6 months to see the sleep person and
Long time.
kind of fragment their care too.
Right. Well, this has been incredibly engaging and meaningful and educational. I've gotten, personally, I've gotten a lot from this. I'm sure the audience is as well.
Well, thank you. And you ask really good questions, actually. They're not easy questions. I really appreciate that.
Well, with the experience that you have and the knowledge that you have, we gotta make you put it to use. It doesn't do any good if it's just staying in your head, right?
You're right. Yeah, it's better. It has to serve. The best knowledge is the knowledge that serves. Yes.
All right. So, folks, there we have it. We have Dr. Anne Germain, who's talked to us all about sleep and sleep disorders and treatments and A to Z of what you might want to know. So thank you for joining us on this episode. Dr. Germain, thank you so much for taking time out of your day to spend with my audience. And I look forward to working more on this in the future because, like I said, I'm also now working in the sleep area and it's exciting.
Great. Well, thank you. And yes, we need you in the sleep area.
Thanks so much.